Hello, this video is for Nurse 5226, Adult Gerontology Acute and Critical Illness, Part 2. My name is Ronald Torres. This is webcam case study number 1. I have here a 70-year-old female with a prior medical history of hard of hearing, hypertension, and an everyday smoker. No known drug allergies for this patient. She was a transfer from Denver, New Mexico for a higher level of care with nephrology and IR consultation and evaluation for abnormal CT findings in the prior facility that showed suspicion of infarction of the left kidney. Upon evaluation of this patient, she has learned orange times 3, no acute distress, she follows commands. She was noted with hard of hearing, but able to provide her history. Her air was pan O2 sats were greater than 92% on the air. Her heart was regular rate and rhythm. Reported some epigastric tenderness that originally started on July the 3rd of 2020, which rated to the back and the left flank, and pain worsened to a level of 8 out of 10. Associated symptoms with this patient included nausea and vomiting. The CT findings from the prior facility was done with IV contrast and noted a large area hyperperfusion of the left kidney, involving 2/3 of the left kidney and suspicion of the infarction. A small area of hyperperfusion was noted in the lower part of the right kidney, which also may reflect infarction of the right kidney. Nephrology was consulted and recommendations were made for IR and evaluation to our facility. Prior medical history stated as above. Surgical history includes partial hysterectomy. Family history includes coronary artery disease and leukemia. Social history, she's a current smoker, 2 packs per day for the last 60 years. And she is positive for occasional alcohol use and denied any illicit drug use. For review of systems, a 12-point review of systems was performed, pertinent and positive negatives, as mentioned, per the HBI. Now, physical exam, her vitals was as follows: an A7.3, oral temp 68, heart rate, blood pressure 124/58, respiration rate 18, and a 94 on room air. For this patient, general, she was cooperative, no acute distress, no normal hygiene and appearance. HENT, her head was normal, cephalic, atraumatic, pupils equal round reactive, so light and accommodating. She had a bilateral hearing deficit, does not use any hearing devices. Her normal nasal mucosa was noted, normal oral pharynx, nor edema nor exudates in the oral pharynx. Nor cervical lymphadenopathy, and the trachea was midline. Cardiovascular wise, no JVD, normal distal pulses, regular rate and rhythm. S1, S2 were audible, and hemodynamically stable. Pulmonary, bilateral chest rise and fall. Clear to auscultation, no wheezing, no rales, no rhonchi. Abdomen, she had normal bowel sounds, but positive epigastric tenderness upon palpitation and non-distended abdomen. GU, positive left-sided CVA tenderness. Patient was oliguric at 200-400 ml throughout the day. It was noted for this patient on the first day of evaluation. Extremities, no cyanosis, no clumping, no edema noted. Skin, normal appearance, temperature, and no bruising for this patient. Submission plan for this patient. I'll relay my last section. I will go over the labs for this patient that was noted. White blood cell count of 22.92, so leukocytosis, hemoglobin 11.0, hematocrit 347, and platelet 327. APTT of 55.4, and a sodium of 135, potassium 3.6, chloride of 102, bicarb 23.1, anion gap of 13.5, BUN of 20, creatinine 0.79, and glucose of 102. Calcium of 6.8. Patient's liver enzymes were as follows: AST of 23, ALT of 13, alkaline phosphate of 90, total protein 3.7, albumin 2.1. We also performed a lupus anticoagulant PTT mix of 51.6, and also some other blood studies for this patient, considering the infarction in her renally. We did a protein C activity, which came out with a normal limit of 67, a protein S activity of 48, factor 5 later mutation that was negative. Biopsy was performed for this patient. The C-ANCA antibodies was less than 1/20, and typical P-ANCA less than 1/20, P-ANCA antibodies less than 1/20, glomerular membrane antibodies 2, anti-cardiolipin immunoglobulin G antibody less than 9, anti-streptolysin antibody less than 20. Blood smear was performed with the patient and is found with neutrophilic leukocytosis with toxic granulations and left shift. There was normal hemoglobin, normal hematocrit, and red blood cell morphology. Normal platelet count and morphology was found. Abdomen 2 view was performed with the patient, finding suggestive ileus versus small bowel obstruction slightly improved in comparison to the prior exam. And CT abdomen was performed in the prior facility, as was explained in the HBI. Assessment of plan: epigastric abdominal pain radiates to the left flank. 2 would be left kidney hyperperfusion, suspected infarction. For those 2, get admitted to the med floor. Nephro was consulted, and further evaluation and recommendations appreciated by the provider. IR consultation for eval and recommendations are followed from the nephrology. A CT abdomen was performed with IV contrast done from transfer facility. Keep the patient NPO for the SBO and possible surgery. Heparin drip was started per hospital protocol. A stat ultrasound bilateral was ordered for the patient renal. IV fluids for this patient, a normal saline 125 ml per hour, with a monitor and control IV fluids, strict I's and O's. Avoid nephrotoxic agents. IV contrast was given prior to, so avoid any NSAIDs and continue to monitor kidney function for this patient. For her hypertension, control her BPs, monitor with hydralazine and IV PRN, and resume her home meds. Patient was hard of hearing with no medical interventions for such. This patient was also found with as stated with the abdomen X-ray with a small bowel obstruction with enteritis. So she was started on IV antibiotics, Zosyn and vancomycin. The abdominal X-ray that was performed, as was stated, showed the persistent SBO. We'll repeat the abdomen X-ray with contrast to reveal and re-eval the SBO. Contrast to be used with statin as a nephroprotective agent. We will follow. General surgery was consulted and follow the recommendations made by the provider. An NG tube was placed in the patient with low intermittent wall suction. Continue to encourage the ambulation for the patient and continue with NPO. For the bilateral kidney infarction, hypercoagulable workup was performed and monitored. This is likely due to her tobacco use, 60 years, 2 packs per day. Continue to use the heparin drip, and the small bowel obstruction will resolve and transition to oral anticoagulants prior to discharge. So we'll change her heparin to novel oral anticoagulants for this patient. For the leukocytosis, from the first day we saw her to the second day that I had her, there was an initial uptrend, and that's why we started on the Zosyn and the vancomycin. Vancomycin was to be renal dosed, considering the renal infarction for this patient, and tightly monitored. Infectious disease consultation was made for this patient to continue if this medication should continue, I should rather say. So we continue to monitor this patient. A repeat blood culture was done. The first one was done from the prior facility, and also to follow up with urinalysis for this patient to see if there's any urine culture that can be provided. For the acute kidney injury, the creatinine from the first day to second day to the other days that I followed up with the preceptor by phone call to see how this patient did. Look like her creatinine was slightly improved, and the acute kidney injury was secondary to infarction, and due to the smoking and hypertensive nephropathy. Patient was for tobacco use was given a nicotine patch and gum used on a PRN basis, and smoking cessation was provided for this patient. Moderate malnutrition for this patient, secondary to poor PO intake, and the patient was put in for evaluation with nutritionist to start on PPN to have a midline place for a PPN for this patient. Appreciate the nutritionist recommendations. This patient was found 4 days after the initial day that I saw her, that her small bowel obstruction continued to get worse and was found with a necrotic bowel. The surgeon immediately performed an X-lap on the patient and performed a colon resection with colostomy. The renal infarction continued, however, her creatinine numbers continued to downtrend, and she remained oliguric but still produced urine. She was not a candidate for hemodialysis yet per nephrologist. Just continue to monitor for this patient. Total time with this patient that I spent in the first 2 days was over 2 hours. A really complex, unknown set of systems that caused the renal infarction and the SBO. The thought was possibly due to the smoking. My suspicion was leaning towards thrombosis, but still with the coax studies, none to show proof of that at this time or within later time. So a very unique patient, very unique set of circumstances for this singular female. Covered many different areas, not just one system. The great thing was hemodynamically and pulmonary was within normal limits, and none of those were decompensated the whole time that I saw her. Very interesting case. Thank you.